concussion has become a problem for two reasons in sport. Number one is the fundamental misunderstandings around what concussion is and how it presents in different individuals. The second being, how do we handle a concussion when we suspect it has occurred? Who are the right people to go to? How do we know how severe it is? But most of all, how do we ensure a safe return to sport for the athlete who's been affected? In this interview, I have Dr. Mike Drzewiecki, who is a co-owner of the Neurological Wellness Institute in Chicago. They specialize in a form of rehabilitation which takes a brain-based approach. They have rehabbed individuals from the NHL who've experienced very severe life-altering concussions, as well as a wide range of individuals who have been affected by whiplash, concussion, and head injury. He knows what he's talking about. I've been trying to get an interview with him for a very long time. He's my go-to guy for these types of incidents. So I hope that you all can take something really useful from this. And if you have any questions, of course, please reach out and let's have a discussion around how to protect our athletes from this type of injury. Here we are with Dr. Mike Drzewiecki, who's a longtime friend of mine and also is very much my go-to guy for any complicated clinical cases I have that are related to neurological issues, head injuries, certain developmental issues. In fact, helped me look after one of my children at a certain point. I was able to go up there and spend some time with him in Chicago. Very well-rounded practitioner, not just focused on neurological issues, but works with a very broad spectrum. So just a fantastic knowledge base. He's here today because he's going to discuss a little bit about his approach, his outlook, and his philosophies towards specifically concussion or MTBIs or whatever you want to call them, and also explain a little bit about the nature of his work and the characteristics of some of the individuals he sees. Mike, thank you for coming on and spending a little bit of time with us today. Hopefully I've done you justice with the introduction there, but maybe you just want to tell us a little bit more about your setup there in Chicago and in the suburbs also.
Yeah, absolutely. Thank you. Absolutely. And I appreciate you having me on here. It's very nice. So, so I'm the director of clinical neuroscience here at the Neurological Wellness Institute. I work primarily out of the Wooddale office, which is a suburb of Chicago. It's about, I guess we're about 40 minutes just outside of right downtown. We do have an office right downtown in the city. And then we just opened an office in Florida this last May in Boca Raton. So we have an office down there, and then we're looking at expanding out and in the works right now of an office in Wisconsin too. So kind of branching out a little bit more too, but that's where our current locations are. And our office primarily is a neuro rehab facility. So we look at everything. A lot of what we see is concussion, TBI. That's really I don't want to say a full majority, but it's a lot of what we see, and then other neurological cases, anything from dizziness to autonomic issues to even seeing child developmental disorders and anxiety and things like that. And a lot of these things kind of overlap with the concussions and head injury parts, right? So we see somebody coming in primarily with a dizziness syndrome, let's say, or an autonomic issue, POTS, or general dysautonomia, or whatever it might be, and then come to find out they had 2 or 3 concussions over a span of the last 3 to 5 years type thing, and you start to connect these dots and say, well, this chronic dizziness that you have, or this chronic dysautonomia or autonomic dysfunction that you have, is probably linked to the head injuries that you sustained over the last couple of years or over the time playing sports, and sometimes it's sports related stuff. Sometimes it's slips and falls and car accidents and things like that. But that's the majority of what we see on a day-to-day basis, all the way down to musculoskeletal things too, right? So sometimes you look at concussions and you have the neck issues that are in conjunction with that, right? So it's kind of no way to hit your head without having some neck involvement, and sometimes it's a primary neck issue that we have to take a look at, and sometimes it's not. Sometimes the cervical issues are secondary to the head injury things, just like the dizziness and autonomic stuff that I was mentioning.
So, Mike, your clinic is specialized. I mean, you do work with a broad spectrum of conditions, primarily, I would say, related to with a neurological component.
Mm-hmm.
I think people are probably used to the idea of a neurologist that treats maybe acquired neurological conditions, so things like MS or a stroke, as well as genetic conditions such as muscular dystrophy or those types of things. But what would you say is the major differentiator between what you guys are doing versus
Mm-hmm.
a primarily a medical neurologist type approach? How do you look
Sure.
at things?
Absolutely, yeah. So I think the biggest differentiator is that um, in traditional medical neurology, they're the specialists. They're very good at diagnosing conditions, and it can be any condition that's neurologically based, like you were describing. Some acquired, some genetic, weird, random neural things, but they're really good at diagnosing that. And then that's about where it ends, right? So they're good at the diagnosis. They can give pharmacological or prescription recommendations to their patients, of course. But then for the types of things that we see or the demographics that we would share, they are often sending those people out to a physical therapist or a vestibular rehabilitation clinic or a vision therapy or psychological therapy, things like that, right? So they send them out after they've diagnosed them. And the biggest difference is that we look at those same conditions. We do a very extensive, let's say 3-hour exam is really what our initial intake is. It involves many different diagnostic tests. We spend a long time with the patient going over a very detailed history, a very detailed physical exam, neurological exam to come up with the best diagnosis for that patient, very specific diagnosis. But then instead of sending the patient out to a different facility, we do all of the rehab in office, right? So we then, a patient comes in, they see me, we go through this entire exam, diagnostics, diagnosis, and then I say, okay, I'm going to build a treatment plan for you that I'm going to be administering myself, and with my team, my therapist that works with me, and I'm with that patient every day that they come in. So any time that they're in the office, I'm seeing them, I'm hands on with them, I'm the one doing the rehab with them, and then also monitoring their progression. Right? So looking at how their objective findings are changing. So it's kind of a cross between neurology and physical rehabilitation. And I would say that's the biggest differentiator. Whereas in the medical neurology field, they might send somebody out, they go do 3 or 4 weeks of physical rehab, and then come back and check in. And that's kind of the basis that they go off of most times for these types of conditions.
That gives us a really good visualization of how your clinic works. I mean, having been there, it's a place that you almost have to see to understand the level of technology that you guys are applying, as well as the skill of the practitioners and the support team. The the good thing I think about what you're doing is you're working with some of the more complex concussive cases or people who have maybe failed rehab or haven't recovered in the normal timeline. But maybe let's take a step back and say, well, when somebody's presenting with a concussion, what are the different, because there are different types or subtypes of concussion, but there's also different mechanisms of injury, and I think they get overlooked and underreported.
Sure, absolutely, yeah, and that's kind of a two-part question here. I guess we could say that there are. Let's start with the physiology of it, or what is the current understanding or theory of how a concussion happens, and kind of more of the older model of what people used to think would happen was this counter coup injury, where someone would hit their head on whatever in sports or on the ground, wherever it might be, but they hit their head and the brain sloshes forward, hits the front of the skull, and then sloshes back and hits the back, and there's damage to the brain because of that. Those things can absolutely happen. You see counter coup injuries, and usually that results in bleeding on the brain, and that's a pretty severe injury. When we see mild TBIs, those would be more considered now a a full TBI, traumatic brain injury, where you actually have bleeding. With the mild TBIs, the current thought process, or there's two of them, that there's this the injury is not so much a smashing of the brain, but it's that when the head is contacted, when it's hit, because our head is sitting on a neck that moves in all these different directions, especially rotational directions, that when the head is hit, there's no way to not have a torsion of the head or a twisting of the neck. And because of how our brain sort of floats in a fluid-filled sac, I mean, it's connected to our skull with these little connective tissues, but there is that fluid-filled sac that's in there, and there's a very quick moment when that head is impacted that there's a twisting of the head and twisting of the neck, and just that quick twisting, because of the brain somewhat being suspended and then being connected to the spinal cord, and then the cord runs all the way down and is more anchored. It's almost like a water balloon type effect. If you're holding onto a water balloon and you quickly twist it, the water on the inside kind of stays where it is. That same theory is thought of with these torsional head injury type things, or twisting head injuries, where there's a slight moment of a twisting of the brain, and the other structures, especially the midline structures, are held stationary, or they're held still. So what you have is a rotation of the brain and a stationary cord and stationary brainstem, and so you end up with a slight twisting or a torsion in that brainstem. And it's not enough that it doesn't tear the brainstem or nothing like that, but what they think happens is that there's a lengthening or a twisting or a torsion of those very fine and very delicate fibers that run through the brainstem, and that's where we get these concussive type injuries. It's where you can have loss of consciousness because of some of the mechanisms in the brainstem that keep us awake and keep us going. So that's where you see loss of consciousness. Very specifically, I see a lot of vestibular issues with concussions. It's a pretty common side of or effect of concussions is dizziness and visual issues and vertigo and nausea and all of that. And when you look very midline in that brainstem and these very midline structures that might have the most amount of torque placed on them because of that twisting, you see the vestibular structures, the central vestibular structures, not just the vestibular peripheral apparatus, which is more peripheral, but really where all those nerves run through and where they join and where they're integrated is in that vestibular system, which is very midline in the brainstem. So when you get these twisting type things going on, it can functionally damage those fibers, and that's where a thought process or theory on the current concussion model is. There's also theory of midline damage. I think people are really starting to understand that these midline structures are greatly affected in concussions, and there's another theory that straight line forces going through the skull, anytime there's a force that is contacted with the skull, you have this force that can be generated through or to the middle. There is and I have to give credit where credit is due. I learned this and this idea from Dr. Joe Clark. He was with the University of Cincinnati when I was working with him there. But the idea that if you have the outside of your skull as a parabola, right, forces coming into that should bounce off of it, right? So you have this kind of effect of forces coming in and bouncing off of the skull. But on the inside of a parabola, from a physics standpoint, on the inside of the parabola, the forces are directed all centrally, right? So when you have a force coming the outside, the outside force gets directed outwards, but any force that's traveling on the inside of the parabola, then they all kind of converge in this middle area. And that middle area of the brain, again, we look at brainstem and we look at basal ganglia and we look at limbic system structures and things like that. That's another thought process that we might have an amplification of force in those midline structures because of just the way that the structure of the skull. So those are kind of the two theories now that are predominant as compared to this coup counter coup type thought process. And I think that was the one part of your question. And then the other part is that there's these different subcategories of concussion, and that's, I think, the hardest part. And I was actually having a conversation with a patient about this yesterday. Was asking a similar question that you asked, but the hardest part about defining a concussion is that it's different for everybody. And that creates a problem in medicine, because we like to have a specific category that says, well, you see this subjective complaint, this objective finding, it means this diagnosis. You look at an ACL injury, let's say, something, or a ligament injury, it's pretty easy or clear. You say, well, there's different grades to the injury. Is it a contusion to the ligament? Is it a partial tear? Is it a full tear? We can categorize these things and say, well, it either is an ACL injury or it's not. And then we look at different diagnoses. When you look at concussion, there's so many different symptoms. There's so many different objective findings, and they can all be intermixed. And because the brain is so complex, it's not as easy as looking at it and saying, here's a subjective complaint, here's an objective finding, here's the diagnosis of concussion. And to get into that, there's the different types of subcategories of these concussions that I see, at least, and some people have described these. I'd say there's probably 5 of them. I think, and people have different thought processes on this, but I see this quite a bit. A very common one is the physiologic concussion symptoms or cascade, and those are the people that are describing light sensitivity, nausea, brain fog, and some of there's overlap from these different categories. But those ones where they're like, man, I'm just not myself, or you hear family members and they're like, his personality kind of changed a little bit, or he just seems a little slower, not quite clicking on all cylinders. That's that physiologic, maybe neurometabolic type effect, or type of concussion. We look at a cervicogenic, and I kind of touched on that earlier, where you say, okay, there's a major cervical component to these concussions. Is it the neck that is primary and causing vestibular or visual or even headache type things? Or is it that there's something that happened with the brain that is then causing a tightening down of those neck muscles and pain in the neck, right? So you have the cervicogenic type headache. So far I said physiologic, cervicogenic. The limbic system ones are interesting, and that's where concussions can be put in some categories in the functional disorder category, or functional neurological disorder, because you can't take an image of the brain, CT, MRI, anything, and say, that's where the concussion is. Right? Imaging is typically very clean with concussions, even though somebody can be completely debilitated from it. And these limbic system ones, those are the concussions where you see people where their primary complaint is, I'm super anxious now. All of a sudden, I have no idea. I wasn't an anxious person before. I was super calm, collected, got a head injury, and now I am crazy anxious. I have panic attacks, or I'm depressed, or suicidal ideation. All these things that can come in, and they were different than what people had before, or their personalities were before. They can be very angry, or I've seen complete personality shifts where, I'll be talking to a wife of a patient, and she's like, he's completely different than he was before. I had one that, it's interesting, went kind of in I don't know, maybe a positive direction, but it's negative in a sense that his personality changed, but positive in that he went from kind of a short fused, angry, ornery guy to kind of a pleasant, funny, joking guy. So that's kind of in a general term, maybe a good thing, but it definitely messed with family dynamics a little bit, because his kids grew up with dad being a certain way, wife married to a guy who was a certain way, and all of a sudden after a head injury, it switched, it changed. So those are those limbic system ones, and I think those are commonly seen, especially with the structures that I was describing with that direct force. Really, when we look at, if you were to look at the angle of all of those different direct forces, it really hits that basal ganglia and the limbic system structures in the midline of the brain. So that's 3. And then another one is your autonomic concussion. I see that a lot. I see a big population that we see is young females, female athletes, coming into puberty, just kind of working their way through puberty, that type of thing, where their autonomic system is already in a major flux because of new menstrual cycle type things. And then they get a head injury on top of that, and suddenly their autonomic system is crushed. They have postural orthostatic tachycardia syndrome, massive autonomic windup. So you see sweating, crazy sweating, sweaty hands, sweaty feet, but cold at the same time. So that cold and clammy type thing. Blood pressure changes, orthostatic disruption or intolerance, where they go from lying down to standing up and their blood pressure drops and they get all dizzy and their heart rate goes through the roof. So that's the autonomic component. And sometimes I have people who come in and they have a concussion and they don't have any other symptoms. They don't have any neck pain. I don't have dizziness. I don't have any of these things, but their autonomic system is completely whacked. And then the big one that I see, and probably the most prominent one that I see, and probably a lot of people see in the concussion world, is the vestibular type concussion. Dizziness, blurred vision, nausea, vertigo, just this feeling of disorientation, or I feel like I'm rocking on a boat all the time. I can't run. I can't play my sport. I can't skate. The big thing with hockey players, it's a very fast sport. High speed. There's a lot of visual information passing past you quickly. Even faster than running, right? So it's very high speed. And then you're having to make quick turns and cuts very regularly. And there's this, when you're turning on skates, you have a centripetal force type thing that is pretty strong, more so than a lot of times with running. And that, if your vestibular system can't handle that load, and I see hockey players all the time, they're like, I can't turn to my right, or I can't turn to my left, or I can't turn at all, with all of a sudden coming out of a turn and being disoriented. And then I'm trying to catch a pass or make a pass or take a shot, and being disoriented at the same time is really, really difficult. So I think very long answer to your couple of questions there, but yeah, those are the main things that I see from a concussion standpoint.
It was good actually, because I think understanding the pathophysiology, as in what we think happens to the brain, really explains why you see that broad spectrum of symptoms. And the reality is there's a lot of blend anyway, because there's this idea in medicine that everybody has to have this one thing and we just treat that one thing. And the difficulty with brain injuries is that there could be several concomitant things happening at once. And what I'd like to take that onto then is the incidence and then also prevalence of this condition, or maybe I think there's a misconception about how hard somebody has to be hit in order to sustain a concussion. And you also mentioned that there are demographics of people, and particularly young females and elderly, but that are more inclined to be concussed, or would take a lesser force perhaps in general to injure them. Has that been your experience practice-wise?
You look at the diagnostics on these guys and you examine them afterwards, and you go, hey, you're okay. Like, you're actually okay. It's not just that you're toughing it out or whatever. And then you see other hits, especially I see a lot of female hockey players. It's supposed to be a non-contact sport, and you see concussions in a non-contact sport like female hockey. And some of that can be just an unseen or an unknown hit to the head that causes twisting of the head, right? So even in non-contact hockey, there's times going into the boards or even cutting across the ice, whatever it might be, where someone is looking behind them and their head is turned, and someone is cutting in front, trying to take the puck away or trying to separate them from the puck, not making direct contact with them in a forceful way, but maybe their shoulder pad catches their chin as they go by. And especially in those ones where you don't see it coming, you can't brace for it, you can't tighten your neck, you can't do anything to try to prevent twisting of the head, and you get this torsional head type thing going on, and you see those ones, and suddenly you see the person go down and they're out, they have to be helped off the ice, they're dizzy, their legs are wobbly, they're Bambi type thing. And you go, well, how could somebody take such a massive hit that you see and pop right up and have no problem, and then somebody else take a little bit of a hit to the chin, and it happens in, I was just using women's hockey as an example, being non-contact, but happens in men's hockey all the time too, where somebody gets just a little hit to the chin type thing, and they go down, and all of a sudden they're out, and they're on injured reserve and all that, and you go, how could there be such a difference? It's not just the force of the hit isn't directly related or directly linear to the severity of the concussion or symptoms that come with that. Absolutely. Yeah. I think your other part of the question was demographics of people that I see. It's all over. It's all over. I mean, yes, I think that people who are, you look at the elderly, of course, people are maybe more vulnerable to falling, and then maybe not having the perfect reflexes or the strength to catch themselves appropriately. So that's a big one. I see concussions all the way through kind of all demographics. Yes, especially those autonomic type issues in young females, like I said, because of going through hormone changes and newly into puberty or menstrual cycles. There's a lot of change going on there. There's different times of the month, of course, and different times of the cycle, of the menstrual cycle that people or women are more vulnerable to injuries of any sort. It's not just head injuries, but I was reading something not too long ago about increased incidence of ACL injuries in the week before menstruation, and it's pretty significant, right? So it can be any injury, and of course, head injuries fall under that.
So the direction we're going in here is now looking at concussions and the occurrence, and we're talking as though everybody who sustains some type of head injury is going to wind up in your office, but actually in reality, the major consideration, so if an impact happens, and let's just say on the ice or on the field, the first thing we're actually going to be going through is a thing called the Glasgow Coma Scale, and although we don't really need to really break that down, what we're really looking at is, well, did they lose consciousness? If so, for how long? And was there any amnesia, forgetfulness, either antegrade or retrograde? And if they're responsive and they're up, okay, now we're moving into our wheelhouse, and I just want to make that quite clear that we're really not talking about sideline care here. The idea is that that's an emergency situation potentially. Then from there, there's a sort of saying that a lot of concussions or head injuries resolve spontaneously, and that's probably not entirely correct. What that means to say is there are subclinical symptoms that aren't severe enough to visit a practitioner, but could have some level of impact. And where I'm going with that is we ran baseline concussion screenings for asymptomatic younger individuals earlier this season. I know you guys do something quite similar. What type of things in a baseline would be of interest, so that if somebody does sustain an injury and there's any suspicion that it could have affected somebody in the way that we've described, what does that comprise of?
Yeah. It's a very good point. For sure, the stuff that we're talking about and the patients that I see is not sideline stuff. Of course, there's emergency medicine, and there's the different, like you said, Glasgow Coma Scale, and there's the different tests to do on the sideline. Of course, if anybody is losing consciousness or has lost consciousness or personality changes or they seem different, then of course that's emergency. The people that we're seeing are definitely later stages. It could be a couple days later, it could be months later, it could be years later that I see some of these people. So the spontaneous resolution argument, I think resolution has to be defined perfectly, and is resolution just no symptoms, or is resolution that there is back to perfect baseline? A lot of times there's not a great baseline that is performed on athletes, and if you don't have a great baseline performed, then you don't really know what full resolution is, how to get them back to perfect if you don't really know what their perfect was. It kind of brings in a couple different points, but I think many people say complete resolution is no symptoms, but there's many people that I see that they, maybe they come in to get a baseline, or they come in to just do kind of this is rare, but sometimes people, let's say they are executives, like an executive in a company, and they say, well, I want to come in for neural performance things, make sure my brain is healthy, make sure I can do everything I can to keep my company running perfect. And then we run some of these tests on them, and we find issues, we find errors, and errors in eye movements, errors in balance, errors in whatever, and they look like a concussion. And we say, well, do you have any symptoms? And they said, no, I'm really just in here for performance, cognitive performance things. And then they say, but I did play football when I was in college, or back in the day, and there's maybe some issues that are lingering around from an objective standpoint: abnormal eye movements, irregular pursuit mechanisms, or slowing of saccade speeds, or whatever it might be, balance errors. And you say, well, there might be some lingering objective findings from your concussions. So does that mean that their concussion fully resolved, or did they set up compensations? Did their brain set up compensations to allow them to carry on with their everyday life symptoms, right? So then I guess the question comes in is, what is resolution? Is resolution no symptoms, or is resolution back to perfect neuro function? So that's one thing, and that goes right into the baseline. And getting a baseline is massively important. We push this a lot. Sometimes it's just like I look at it as like an insurance policy. You don't need insurance, and it is kind of annoying paying insurance policies until you need it, right? That's the thing. The same thing with the baselines. It's you got to take time out of your day for a baseline. You have to come in and get it done, whatever it might be, and you may never need it. You hope that you don't need it, but then if you have a head injury, especially if you're playing sports, you have a head injury, it's good to then have that baseline so that you can look at it and say, one, did I actually have an injury? Is there a problem? And if there is, then we compare it to your baseline. We say, yes, there was a problem, and then we have to fix it and try to get you back to your baseline through rehab. Or the other thing that happens sometimes too is they're worried, right? They hit their head, they got hit pretty hard, they think they had some symptoms, maybe it lasted for a day, maybe not, maybe their neck was stiff, and they come in and we compare them to their true baseline, and we say, no, actually things check out, they look good. You're good to go, and you can now go back to your sport, whether at an amateur level or a professional level, and you can feel comfortable going full speed because you don't have to worry about these head injuries, because we've actually shown that from your baseline there wasn't any change in that hit that you received. So that's a huge thing about baselines, and the ones that we run are very extensive. Some baselines, they look at just jumping from dot to dot to dot and timing that, or letter to letter, how quick does that go? And that's one thing. Other ones are just symptom scores. Do you have any symptoms? That's one kind of baseline. There's other ones that try to bring in some balance effect. There's very few are fully inclusive eye movement screening, and that's really where ours comes in. We look at all the different types of eye movements, reflexive eye movements. So in the dark eye movements, are there any spontaneous eye movements? And we're using a video nystagmography goggle system that measures eye movements. And we look at pursuit mechanisms. We look at saccade mechanisms. We look at optic kinetics. We look at gaze stability. We look at many different biomarkers to brain health from an eye movement standpoint, but then also look at balance testing on a force platform. We look at these balance in different head positions, which becomes super important after you've had a head injury. If your balance is good with your head neutral, but if you tilt your head back and your balance gets very poor, or you fall, then obviously that's an issue. So we look at balance. We do look at some cognitive things. So we do some cognitive testing using an iPad platform that measures cognitive processing speed and things like that. And then we also look at autonomics, even in our baseline. We look at heart rate, blood pressure, SpO2, and we're looking at that in multiple positions: lying down, seated, standing. So we get a full picture of what as many biomarkers as we can of brain health, looking at kind of those 5 different concussion categories I was describing earlier. And that's the baseline. And it's an extensive baseline. It takes time to do those things. But I can't tell you how many people who have gotten the baseline that then say that they're extremely happy that they did after they do hit their head, but also how many people that come in after a head injury and are bummed that they don't have a baseline to compare where they were before. So that's the baseline is a big deal. It's just hard to get people to fully jump on board with that.
Great summary of why a concussion baseline is important, or any type of baseline testing is important for a developing athlete, but actually for an athlete at any level, or somebody even returning to sport, is is critical and important part. And I think you rightly pointed out what a comprehensive and thorough battery of tests and examinations that actually is. It goes slightly beyond something that, if you look at cognition, it's just one dimension of a baseline, but there's far more to it. And I think that is really valuable thing to understand.
Absolutely.
So we've talked a little bit about, well, what tools are there available and what do we do to deal with these things. But as a parent or coach or non-medically trained professional, what should we do if we suspect that somebody could be experiencing signs or symptoms of a lingering concussion? Because we sort of said previously that the parents will come and comment, oh, something's not quite right, or they're not quite themselves. So what sort of things are we looking at where we might want to seek help?
For sure, yeah, and important point, kind of what we discussed earlier. There's kind of two levels to it. Of course, if you're suspecting a concussion, let's say, and sometimes these things present even the day after or later on. You might have a kid might have a game earlier on in the day and get hit, maybe feel something right away, maybe not, and then all of a sudden they get home and then the headache starts and then the dizziness, and it doesn't have to be right away. So if they've not been or it wasn't a major injury on the ice where they're immediately taken to a emergency professional, or whether it's a clinic or a hospital or whatever it might be, even at that point, if it's later on in that night or that day or even the next day, if all of a sudden these things start to pop up, then you have to get that person into emergency room or local clinic or whatever it might be for initial evaluation. Past that, if there's lingering things, then of course you want to try to find the typical portal of entry type practitioner, right? So most times people will take their kids to a GP or themselves. They might, if they're older, they might go to their GP. A lot of times they then get kind of routed where it might be best. Sometimes it's neurology to a neurologist. Sometimes it's right to a physical therapist. Of course, now, my bias, we have, we're portal of entry providers too. So we have more and more people that are coming directly to us because of, just knowing that we deal with and see a lot of head injuries and concussions. So we have people coming right to us, of course, but just in general, looking for somebody that deals specifically with concussions. And there are a lot of vestibular rehabilitation clinics, physical therapy centers that deal with concussions and understand that, and that's not every physical therapy clinic, let's say, and that's definitely not every chiropractic office or physio. So finding somebody who specializes in it is important. And then of course, trying to, my bias, knowing that there's a certain group of us, even though it's a relatively small group compared to the general population, is, I was trained by the Kirk Institute. I know the training there, of course, and know the people who have been trained by the Kirk Institute, and those are people that would be good to seek out if they're in your area. But of course, that's not in every area. So then it's really just a matter of finding and knowing that there's somebody that actually deals with concussions or specializes in concussions around you, and that's who they should be seeking out.
Important question that probably fits in here. The sleep issue, we're asked to keep an eye on individuals if we suspect they've had a concussion or a head injury.
Sure.
Don't let them sleep is probably outdated advice. Would that be fair?
Yeah, absolutely. The idea before, and it was maybe good advice with the knowledge that was had at the time, but it's outdated. The idea before was to keep people awake so that there was no risk of, let's say, bleeding on the brain that then causes or slow, because a lot of times with head injuries, you can have a slow bleed as bleed, and a fast bleed, of course, right away, like a stroke type thing. Sometimes these slow bleeds, they can take some time, and the worry is that somebody will fall asleep and then not wake up because the bleed happens through the night type thing. So the thought was always, well, keep the person awake or wake them up every hour or whatever the time frame is, to make sure that this isn't happening. If they're suspected, the big thing is if someone takes a hard enough hit and you see symptoms right away, then they need to go to the emergency room, and usually a CT scan will be performed right away to rule out a bleed. If that happens, then and they rule it out, they say there's no bleed, you're good, then the best thing is to allow people to recover, and the brain recovers during sleep. So to be waking that person up every hour or every other hour, you're just disrupting that sleep cycle of the first night, and that can be when a lot of healing actually takes place, and the metabolic processes to try to clean out inflammation and damage that might have happened from the head injury takes place while you're sleeping. So yeah, I would say as long as it's been ruled out that there's no bleed, then that is outdated, and let the person get good sleep and rest and recover, just like you would with any injury.
And just to segue from that, the recommended amount of quiet time in a dark room and so forth, which was then the second thing, is go home, rest in a dark room, and don't do anything for 2 weeks, is in every case is nuanced, and there are probably exceptions, but that is not the standard advice anymore.
Correct. Yeah, absolutely. Again, that is outdated a little bit. It's limit stimulation that is symptom provoking. So if it's not symptom provoking and they can be out in the light, or they can be dealing with normal day-to-day activity, as long as it's not significantly increasing their symptoms, then they should be able to do that. Just sticking somebody in a dark room just as a protocol can often cause a down regulation of the nervous system. So then the person comes out of the dark room at some point, they have to, and then the light is really bright or the sounds are really loud because of this adaptation to a lack of stimulus. Whereas they can stimulating environment as long as it's not causing major problems, but if it's one of those where somebody is on their phone or on their computer and they get a massive headache, then they should probably spend less time on their phone or their computer, or whatever that activity might be. But it doesn't necessarily have to be just go sit in a dark room.
And again, very difficult to be specific with this, but what's a general time course of recovery from a concussion? I know it's variable depending upon the severity and the number of incidences, etc.
Yeah, and that's the tough part. That's the somewhat frustrating answer to all things brain, is it depends, right? But it's there's not really a set time frame. Usually we see it's anywhere from, if it is a true concussion, if it's a concussion, you're looking anywhere from days to a month type thing. Is pretty regular. Usually in under 2 months is kind of a general guideline for when people should, like we talked about before, that spontaneous recovery. Really, when you start to see these symptoms lingering more than 3 months, then that's where it starts to, you're getting syndrome. We know that's not going to, quote unquote, spontaneously resolve on its own, things like that. But really, you're looking at symptoms should pretty much be gone within a month. Of course, so we had that whole discussion earlier about whether that's actually resolved or not. That's a different story, but usually that's kind of what we're looking at time frame.
And then just to close out, in terms of, certainly for practitioners, for any PTs, DCs, ATs, LMTs, or any other acronyms profession that's listening to this, further training. So some people won't want to get involved in this side of things, and that's understandable. Dealing with concussions and brain injuries is very specialized course these days. But you mentioned the Carrick Institute. Are there any other resources that we think that people could look at if they want to learn enough to be helpful?
Yeah, that's a tough question. Enough to be helpful is a good point on that. I would say that learning, if it's from a clinician, from any licensed, we'll say therapist, like you were describing, the more you can learn about it, the better equipped you're going to be, and that is different for everybody, and it's different for every profession, and for everybody's ability to perform within their license might be variable. It might be different from state to state, but the more you can learn about these things, and there are all kinds of resources now everywhere. You can find free stuff online that is accurate. There are papers everywhere. There are, and then you can go to different courses. All of my training is through the Kirk Institute. Like I said, that's my bias. But really, I think it's anything that you can learn about the current understanding of head injuries, of concussions. I know the World Concussion Summit was put on hold for because of the pandemic stuff. It was I think 16 was the last one, and there was supposed to be another one in 2020, and of course it got put on hold for everything. But I believe it has either been completed or is coming up here soon. There will be another white paper. I think that conference was already done, so there should be another white paper on everything coming out that is up to date, understanding of concussions and head injuries, and reading that is step one, and then looking at the authors of that and looking for other information. You just can go down the rabbit hole of head injuries, but like I said, my bias is the character series. That's just where I've learned everything.
And I certainly took extra training. I took a master's degree in clinical neuroscience, and then I've taken a number of different courses. Actually, I've taken the concussion course through Carrick, and spent some time with some of those professors and tutors and get involved in these conversations. But I agree. I think the consensus statement, it just took place fall of last year, as I understand it. But the papers haven't been put out into public space. But that being said, the Berlin consensus statement from 2016 is they're not going to modify so dramatically that doesn't hold, and that's a really good place to start as a practitioner, just to make sure that if you're not following these protocols, or if you're not aware of them, that's a great place to at least evaluate where you're at. And when it comes to the coaches / parents, I mean, one of the things that has been in the media, particularly in the last couple of years, is the emergency response to cardiovascular events which happen in the field. But my suggestion, and I think you would agree, is that in addition, if you're a coach, even if you're a volunteer coach, you want to make sure that you have some type of protocol pre-established in place prior to taking responsibility for that team or that group of individuals.
Absolutely. From an emergency standpoint, on field, on ice, on court type thing, having just like any injury, right? Having the safeguards set in place ahead of time to know what the protocol is if someone gets a bad head injury, and oftentimes the head injury is also associated with neck injury, and so knowing when it is safe for a player to move off of the field and when it's not, and when they need to be put in on a board and in a neck brace, how to go through those protocols and it's different for every level. Obviously you have some levels where there's a athletic trainer that's available and that is trained in these things, but there's a lot of youth sports where that's not necessarily the case, and it's not necessarily the coach's expertise to know those things. But again, a coach who doesn't have expertise might really, could go along with saving someone's life to make sure that they stop the game. They call emergency personnel. They don't let someone off of the ice, off of the field if they suspect that there's a major injury, of course, and just having that awareness of how to handle the situations ahead of time, so that it's not trying to figure it out on the fly when there's a lot going on, because obviously that's a recipe for disaster.
I think on that note, Doc, we'll wrap it up.
Sounds good. Well, thank you so much for having me on. I really appreciate it, Nicky.
Yeah, absolutely. Thanks for agreeing to come on and sharing your wealth of knowledge with us. And just so everybody's aware, Dr. Drzewiecki is my key resource that I go to when I have questions around this stuff, and he always delivers, even though he would claim that he doesn't.
Well, thank you. That's very nice. Very nice.
Absolutely.
Yeah, thank you. It was good seeing you as always, Nicky.
Thanks, Mike.
All right.